Hi everyone, my name is Desmond Boachitano, a PGY2 internal medicine resident at Insight Hospital and Medical Center, Chicago, Illinois. I'm here to present a case of chronic thromboembolic pulmonary hypertension, which was initially masked by pneumonia. I'd like to briefly describe what pulmonary hypertension is. This is a condition which results from elevated pressure in the pulmonary arteries, leading to increased resistance and strain on the right side of the heart, ultimately impairing oxygenation and potentially causing right heart failure. Now, chronic thromboembolic pulmonary hypertension, or CTEPH, is a rare but severe form of pulmonary hypertension, which is caused by unresolved thromboemboli in the pulmonary arteries. These persistent clots lead to progressive obstruction of blood flow in the pulmonary vasculature, which in turn causes a significant right heart strain and compromised oxygenation. Due to its symptom overlap with more common respiratory illnesses such as pneumonia, CTEPH often remains undiagnosed until it reaches advanced stages. If left untreated, CTEPH carries a high mortality rate with a life expectancy of only 1 to 3 years. Now the case presentation. We had a 64-year-old female with medical history notable for venous thromboembolism who presented with symptoms of exercise intolerance and non-productive cough. She was found to be febrile, tachypneic, and hypoxic at the ER. Laboratory findings were remarkable for mild leukocytosis, and a chest X-ray demonstrated a right-sided infiltrate, which was suggestive of pneumonia. Now, despite antibiotic therapy, the patient continued to experience persistent hypoxia. A CT angiography excluded acute pulmonary embolism but revealed right ventricular strain. An echocardiogram confirmed severe pulmonary hypertension, and a subsequent VQ scan diagnosed bilateral CTEPH. The patient was initiated on Coumadin and was later on transferred to a tertiary care center for advanced management. CTEPH always portends a poor prognosis if left untreated, with a life expectancy of 1 to 3 years. There's often a diagnostic overlap with more common respiratory conditions like pneumonia, which can delay accurate diagnosis. In this case, initial clinical suspicion was of pneumonia, which was based on chest X-ray findings. The persistence of symptoms despite appropriate antibiotic therapy prompted further investigation. Now, there was a high index of suspicion, which is essential for diagnosing CTEPH, particularly in patients with a history of venous thromboembolism and persistent pulmonary symptoms. A CTA is usually useful for ruling out acute pulmonary embolism and maybe identifying right ventricular strain. An echocardiogram evaluates the severity of pulmonary hypertension and will reveal a right ventricular function. A VQ scan remains the gold standard for diagnosing CTEPH due to its high sensitivity in detecting perfusion defects and chronic thromboembolic obstructions. Anticoagulation therapy, which aims to prevent further thrombus formation and reduce embolic risk, is often initiated. For severe cases, referral to centers with expertise in pulmonary thromboendarterectomy is crucial. This can significantly improve symptoms and patient outcomes. For patients who are deemed inoperable, balloon pulmonary angioplasty is a potential alternative. Effective management involves collaboration among pulmonologists, cardiologists, and vascular surgeons to optimize treatment and improve the patient outcomes. CTEPH should always be considered in the differential diagnosis of patients with persistent dyspnea, especially those with a history of venous thromboembolism. Given its high mortality rate if left untreated, early recognition and appropriate management are critical. Thank you.